Hi, my name is Luciano Costa. I'm a multiple myeloma physician at University of Alabama at Birmingham. And I have a couple of things to comment with you about some important abstracts that are coming out for this summer season of meetings between ASCO and EHA. And one I want to emphasize is a subgroup analysis of the CARTITUDE-4 trial that I had the chance to present at ASCO 2024. That subgroup analysis emphasis is on patients with one prior line of therapy, which I think that's the place where cilta-cel or CAR-T in general is the most controversial. And this subgroup analysis look at patients who have enrolled on cilta-cel versus standard of care on the CARTITUDE-4 trial, and with particular emphasis on the patients that we call have functional high-risk disease. That's disease that is progressing within 18 months of the initial treatment, which is a group that we know historically is very difficult to treat. And overall, the study, as many of you know, it was a positive study showing the cilta-cel outperforms standard of care regimens, which in that trial was PVD or DPD. But in this particular subset of patients with one prior line of therapy, cilta-cel was still beneficial with a reduction in risk of progression or death of 65%. But when you look at the patients with with functional high risk, those patients were the most need, those patients who are progressing within 18 months of therapy, the reduction of risk of progression and death was by 73%. More interestingly, you saw a very stable and high rate of progression-free survival, at 12 months on the cilta-cel arm, both on the overall first one prior line of therapy population, as well as in the functional high risk. While in the control arm, you see really a decline in activity when you go for the overall population to those with functional high risk. So I think the message to take is certainly cilta-cel is not a treatment for everybody with one prior line of therapy experiencing the first progression, but for those patients who are proper candidates for that therapy in terms of toxicity, in particular if they have disease progressing early after the initial treatment or transplant, the cilta-cel becomes a very effective, very attractive option. And the impressive thing about this therapy is the performance seems to be very good and very stable, almost like not mattering how high risk the population is. Of course, there are toxicities associated with cilta-cel that by now most of you know. The low blood counts, the cytokine release syndrome, the neurotoxicity. However, those rates were relatively low, particularly when compared to patients treated much later in their trajectory. And on this particular group of patients with one line of therapy, the toxicity was really not any worse or any more concerning than it is on patients with later lines.